So I have particular interest in assuring that traumatic brain injury patients get optimal care. And one of the ways that traumatic brain injury patients are routinely harmed is through inappropriate ventilation. Now, that can occur either through overventilation, which drives the carbon dioxide levels down and causes blood flow to the brain to actually slow down and potentially even stop. And it can occur through breathing too fast, which puts a lot of pressure in the chest and decreases the blood flow back to the heart, and then again decreases blood flow to the whole body, including the brain. So right now, the best technology available to monitor respiration or ventilation in the field is end-tidal CO2. Right now, I think people are beginning to focus on the actual number and trying to keep that number from going too low. So we generally target an end-tidal CO2 value of 35 to 45, but also to start thinking about how fast the ventilations are occurring and looking at the ventilation rate as well. Well, for years we've considered the ABCs of trauma, airway, breathing, and circulation, and of paramount importance to a head-injured patient was maintaining control of the airway, which often resulted in intubation or putting a tube in to help secure the airway, which then requires that the provider or the rescuer provide positive pressure ventilation, actually provide breaths for the patient. And while that's been seen as life-saving, it also is potentially the quickest way to harm someone by inappropriate ventilation. And so I believe that the lowest hanging fruit in all of trauma care is controlling ventilation right now. So education is extremely important. We produced some data that demonstrate that crews that have had capnography for many years are the ones who provide the best ventilation, that crews that have capnography but aren't used to using it or didn't receive appropriate education do better than crews that don't have capnography altogether, but not as well as they could do if they get proper education and ultimately experience. One of the more interesting uses of capnography is the realization that the end-tidal CO2 value also reflects cardiac output. It reflects how much blood is flowing through the lung, delivering CO2 for an exhaled breath. And so changes in CO2 not only reflect changes in ventilation, but also changes in perfusion, which are critically important to the head-injured patient. So starting to think of end-tidal CO2 as a way to monitor the perfusion status of the patient reflects a growing and important use of capnography. Some of the data that we produced in the hospital setting suggests that end-tidal CO2 may be more valuable than even blood pressure, which has been the standard for many, many years in documenting and measuring perfusion. So that's an area to keep an eye on, and yet another use for end-tidal CO2 in capnography. So I think everyone should have capnography. That should be standard of care when you're taking care of head-injured patients. And if you have capnography, then you have to focus on two things right now. One is keeping the CO2 as close to 35 or between 35 and 40 as possible. And the second is to make sure your ventilation rates stay somewhere between about 8 to 12 breaths per minute. If you can take care of those two things, then you should see dramatic improvements in outcome in your head-injured patients.